Let's talk about sequencing and screening. We want to develop a strategy for how we approach treating a patient and not just check every segment and diagnose and treat all 30 somatic dysfunctions that we have. We want to get the most benefit, highest yield somatic dysfunctions to improve for our patients. So how do you do that? How do you figure out what to do during a treatment? That's what we want to start getting you guys to think about. The method we're going to talk about was developed by Dr. Stiles, Dr. Ed Stiles. He believed that finding the area of greatest restriction, or the key lesion, is the most crucial issue for obtaining good results. He felt that this is getting closer to treating the cause and treating less of the effects. So don't always listen to pain. Don't just chase pain. We want to listen to our patients. We want to use that information as part of a diagnosis. But remember, we treat the patient and the problem and not just the symptom. Dr. Still used to tell a story about stepping on a cat's tail. He said that, I think there's another one that was a rocking chair on a cat's tail. So a cat is screaming. So what do you do to treat the cat? Obviously there's a problem. He's screaming. What do you do? The answer was the surgeon is going to cut off the tongue, maybe the voice, and maybe the larynx, get rid of all that. The person that only prescribes medications is going to give enough medication to knock the cat out so it can't scream anymore, whereas the osteopath will remove his foot or remove the rocking chair from the cat's tail, therefore the cat won't scream. So even though the cat's mouth is making the noise, the problem could be somewhere else, and in this example, the cat's tail. So remember that story if you find yourself just treating the area of pain and try to figure out what's causing the pain. So often the area of greatest restriction or the key lesion isn't completely unrelated to the area of chief complaint. So that's why we want to develop some sort of systematic screening exam. So this is a good exam, a great exam. It's not the only exam. You may encounter other in your clinical practice or other faculty. Those are all probably perfectly valid. This is the one we're going to teach you guys because it fits in well to the biomechanical model. So the idea is to consider tensegrity. So tensegrity is a term that started with a mechanical and architectural term. So it provides the ability to yield increasingly without ultimately breaking. So tensegrity structures are mechanically stable not because of the strength of the individual members, but because of the way the entire structure distributes and balances mechanical stresses. And the more and more studies are showing how the body functions as a tensegrity structure by how it distributes forces and due to its design. So let's look at some tensegrity structures. So there's struts. The rods in these pictures are like bones. The wires are like muscles, tendons, connective tissue, fascia. And so how they're structured can distribute tension and allow for support. So notice none of these rods are actually touching each other. They're all suspended by these wires. So a change in one area is going to affect the tension in the structure all the way up. So let me show you a video of the AGR screen so you know what that looks like. When performing an area of greatest restriction screen, you want to start at the base of the skull near the occiput. Your thumb is going to be ipsilateral to the side you're testing, and you're going to be just lateral to the spinous process, kind of in that gutter of where your hand can sit in, just next to that spinous process. Now the goal, as you can see on the video, is to induce a springing motion into the vertebral segment or segments that you're testing. We're going to utilize Fryette's third law to do this, so that's why we induce a flexion and then a side bending and rotation. So as we flex and side bend and rotate, we're limiting spinal motion. That way when we do a springing motion, we're just checking the quality of the infeel of that spinal or spinal segments. And we finish the standing screen with a standing forward bending test. When you're screening the cervical spine, notice that you're using the hand on the top of the head to induce the side bending and rotation, and you're palpating with the thumb, palpating and springing with the thumb. Whereas as you move below T4, you're using your thenar eminence to do the springing motion and palpation, and using the ipsilateral shoulder to induce a side bending and rotation to the segment that you are screening. This screen is done in a standing and seated position. And then we finish the seated screen by doing a seated forward bending test. All right, now that you've seen the in full speed, um, we're going to show you just step by step how that works. This is actually Harriet Shaw. I borrowed some of her information and figures, so I wanted to give her some credit for that. She works with Dr. Stiles and has taught classes with him, and she was one of my OMM professors. So we want to look for the area of greatest restriction by an articulatory screen of the spine, and then using our standing and seated flexion tests. So we started at the neck, so we're going to palpate facet motion, so it's not just muscle tightness. That's a common error. You feel muscle tightness, that's good information, it's just not what we're feeling for in this particular exam. So we did some slight neck flexion, so that way side bending and rotation occurring to the same side helps with that third law of spinal motion. So we're feeling for infeel. So does it spring, does it move, or does it feel restricted and rigid? So we start with the neck, we go to the upper thoracic, still using the head as a lever for that first upper thoracic, just because you get thoracic motion down to T4 with head movement, and it's just easier than using the shoulder motion that we're going to transition to next. So again, we want to make sure and contact every segment. You can get 2 or 3 at a time, but you don't want to skip areas. Moving down through the thoracic, so you'd want to start again T4, T5, and work your way down the thoracic and lumbar spine, but you're going to use the shoulder to introduce the side bending and rotation. Again, we're localizing to this area and springing the spinal segments for infeel. Perform a standing flexion test. Again, the side that is most superior at the end of at the end of bending is the positive side, because that's the side that the SI joint is restricted on. So in this case, we can see that right side is elevated. So we do that same exam on both sides, and then you would move to a seated exam. So again, cervical area, thoracic area, lumbar area, both sides, and do a seated flexion test. And you can see again, he's got a positive seated flexion test on his right side. So this is a diagram. I'll show you a few diagrams of how to work through that. So if you find the area of greatest restriction, again, what is the most restricted area to motion test? If it's above the diaphragm or above T12, then you want to check, you would assume it's in the upper body. So if it's in the cervical spine, you want to check all the areas of the cervical spine and diagnose the worst and treat the worst. If it's in the thoracic spine, it could be the vertebral, the ribs, or the upper extremity in that area, and we'll talk through that in a minute. If it's below T12 is the area of greatest restriction, then it becomes increasingly more important on these seated and standing flexion test results. But we could consider the lumbars. If it's worse in the lumbar, we'd want to do segmental testing. If it seems to be worse in the pelvis, some more in that sacral iliac area, and you've got a positive seated forward bending test, along with the standing most of the time, then you want to do assess your pelvis and sacrum, and we'll talk about the order in a minute. Or it could be the lower extremity. So if you're screening them and it's really restricted in that lumbar area when they're standing, and then when you sit down, it's not as bad. So the findings are worse when standing. You want to consider the lower extremity, and you might have a positive standing test, which could mean a pelvis problem, but it also could mean a lower extremity problem. You'll have unilateral tightness along that side of the lumbars, and so you want to screen the hip, knee, foot, and ankle. So here's another example illustrating that, how you work through. It could be cervical, the upper, the OAAA, or maybe C2 to C7. Again, is it upper extremity, vertebrae or rib cage? Is it lumbar? Is it pelvis? is it lower extremity? So let's say you find the area of greatest restriction in the cervical spine. So if it's in the upper cervical, it's likely OA or AA, or it even could be a cranial dysfunction. So lots of times those tough lesions up there that aren't resolving with your treatment of the OA or AA, it's likely that those are actually due to cranial somatic dysfunctions. So get some exposure to that this year, but oftentimes additional training is very valuable if you want to treat that to any significant degree. So again, you would treat the most restricted area of the cervical spine of OA or AA, or if it's in the middle lower cervical spine, more likely C2 to C7, you would diagnose and treat the most restricted. So if you find the area of greatest restriction in the thoracic and ribcage area, you want to do a couple of things. You want to check motion testing near the facets, near the midline, closer to the midline where the circle is, and you want to feel how restricted that is to motion testing. Just press with your thumbs anteriorly. And then you want to compare that to going laterally along the rib or multiple ribs in that area. If you feel the restriction gets worse as you palpate along the rib, then you want to think of the rib cage as the area to treat first, versus if it's worse towards the facet, towards the middle, more restricted there, you would diagnose and treat that thoracic vertebrae in that area. So again, if it's ribs, you would want to lay them down and screen out the entire rib cage and then treat the key rib as you've learned. So it's not necessarily just the rib at that level of restriction. You need to find the key rib. So if you find it more in this lateral area, medial to the scapula, unilaterally, that's a classic finding. If that's the worst area of restriction, that leads you to think of an upper extremity somatic dysfunction. So oftentimes patients are complaining of back pain or pain elsewhere, and you've got restriction here, and they're not complaining of upper extremity pain. But this screening exam allows you to find significant somatic dysfunctions of the upper extremity that you would have otherwise missed. So you look for a tight band, vertical band, unilaterally on the side of the problematic or dysfunctional upper extremity. So you've done that. You also do the seated and standing flexion tests. If the seated flexion test is much more positive than standing, then that's going to lead you to sacrum. Again, these are clues, not as many absolutes. It leads you to think the sacrum diagnosis. And if the standing is much more positive than seated, then think innominate or possibly lower extremity. So if there's a unilateral tightness noted in the lumbar area that improves with sitting, then screen the lower extremity. We talked about that. If you find the area of greatest restriction with seated and standing in the lumbar vertebrae, then you want to diagnose and treat the lumbar vertebrae. But if the restriction gets worse as you move closer to the SI, maybe you do feel some lumbar dysfunction, but it gets worse as you go farther down, and you're like, ooh, that's the most restricted near the SI, then that's going to lead you to looking at sacrum and pelvis. So just a couple of items on sacral dysfunction. So you did your seated forward bending test. You also consider the spring test, the sphinx test, which is that backward bending test. And then you also want to look at the ILAs. Those are important because they should be asymmetric if they have a sacral somatic dysfunction, assuming it's not a bilateral flexion or extension. So sometimes they're easier to see that ILA than it is that sacral base level. That sacral base becomes harder to tell the accuracy of it if you've got pelvis somatic dysfunctions. So that ILA can help you sort some of that stuff out. And again, you also want to look at leg lengths, sacral bases. So the more common sacral lesions, which you guys might have found on your classmates already, according to Dr. Stiles, is the left ILA is inferior and posterior. So that includes the left on left torsions, left on right torsions, left flexions, right unilateral extensions. As you may have found, and we've talked about before, you may find multiple somatic dysfunctions in the sacrum and pelvis. So the best way to approach treating them is to treat them in this order. And most of the muscle energy authors would agree on this. to treat the innominate shear and pubic shears first. The reason is if you've got an innominate shear or pubic shear, that's going to disrupt all these sacral axes, so it's going to be a lot harder to diagnose and treat the problems of the sacrum if you've got the pubic axis that's off, or you've got this whole entire shear of the sacroiliac joint due to an innominate shear. So if you have an innominate shear or a pubic shear, you want to treat those first. Next, you want to evaluate the lumbar spine, especially L5, and the sacrum. So you've treated any shears of the pelvis, you check the sacrum, you get a diagnosis, say you get a left-on-left sacral torsion. Now, that should cause the L5 to rotate to the right and side bend to the left. But what a non-compensated L5 means is that it doesn't do that. So if, again, a left-on-left sacral torsion, if that L5 is rotated to the left also, then your muscle energy treatment is not going to be as effective, because the setup position actually is trying to treat the opposite rotated sacrum and lumbar. So if you found a non-compensated L5, one that doesn't fit that normal compensation for torsions, you would want to treat the L5 first so that your treatment to the torsion would then be much more effective. So that's why we put lumbar spine before sacrum if needed. And then you would do your innominate rotations and flares. And a lot of these would have cleared up, not all of them, but lots of times those initial innominate rotations resolve after you treat the shears and sacral somatic dysfunction. So that's the rationale. You've restored the normal axes of motion to the sacrum by correcting the pubic bone and correcting the innominates and correcting L5 if necessary. So now your diagnosis is cleaner and makes more sense, and your treatment will be more effective. Another way to remember these treatment sequencing to help you consider all of these some diagnoses as you're working through the lumbar, sacrum, and pelvis, this Lipple-Sip becomes helpful sometimes. So again, lower extremity, you want to consider and treat that. You may, especially if you have indications on your screening exam that we talked about, that was the unilateral band and the lumbar spine. With standing, the restriction improves significantly. With seated, that was when you would be led to the lower extremity. But also consider it if you're just not getting the results you want. Next, again, innominate shears, then pubic shears, lumbar if it's non-compensated at L5, sacrum, iliac rotations and flares, and psoas. So again, that's just a reminder. Don't forget the psoas as a part of your lower extremity and as a part of your sacrum, pelvis, and lumbars. It attaches to all of those. Some people might even argue to put it up there with lower extremity. If you find it, treat that first. Again, this sequence is just to help you remember how to work through it, and so you don't forget other important structures as you're working through the sacrum and pelvis and lumbars. So why do we do this? Well, oftentimes when we're treating, we do a treatment and it doesn't get that much better, or only that area improves, and then we've got 10 other somatic dysfunctions we need to address. So if our diagnostic patterns don't match the book, you may have found that in the sacrum and pelvis. The sacrum, everything seems to fit one thing, but the seated flexion test didn't match, or the backward bending test didn't match, or something's just not adding up. It doesn't fit the book diagnosis. That's typically because we weren't treating in sequence, and some other aspect of the body was creating a pull and restriction that messed up our diagnostics. Or if you treat a patient and 2 hours later or a day later that exact same somatic dysfunction comes back, you keep popping their back, it keeps coming back, you're likely missing a significant area of restriction that you didn't address because you were only looking for one area, or you wanted to practice one technique, or you're only focusing on the area of pain. So if you do treat a major restriction, at least as a ballpark, 20% of the other dysfunctions should improve, maybe even more. So you go back, you do a rescreen, you're like, man, a lot of those somatic dysfunctions that I found originally have gone away now that I've treated that one area. So you can do a full treatment, you treat that one area, you go back, you rescreen the whole body, area of greatest restriction, and treat the next area of greatest restriction. Working through that, you're often done with 2, 3, 4, 5 body regions. You've treated the whole body adequately. And the goal is to remove major restrictions so the body can heal itself. Again, not not treating every area that hurts or every area that might have a slight somatic dysfunction. We want to remove barriers that are preventing the body from healing itself.